person, she, her. I am lead staff for the Medicaid Advisory Committee, or the MAC. And this is the MAC's public meeting for October 2025 to help fulfill its state and federal mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on running Oregon's Medicaid program. And so I'm going to share a few logistical announcements before we get started. Please mute yourself if you're not speaking. If you are joining by phone, please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you must leave, it's better to hang up and then rejoin the meeting. And MAC members, please use the raise hand button if you have a comment or question, or you can put a note in the chat to let us know you want to speak. The Medicaid Advisory Committee does have built-in time for discussion after each presentation. MAC members will speak first. When we've exhausted questions from MAC members, if there's time remaining for the agenda item, we will take general questions. And we have also 10 minutes for public comment near the end of the meeting. I think it's at 11:30 today. We have ASL and Spanish language interpretation available for today's meeting. You can pin the ASL interpreter's video by clicking on the More button next to their name. There's also a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. And actually, a note that we are splitting things now so that we have an English channel and a Spanish channel, and we encourage folks to choose one or the other channel. And so now I'm going to hand it off to MAC co-chair Caroline Barrett to take us through the first half of our meeting. Dr. Barrett?
Good morning. Welcome, committee members and members of the public. Thank you, everyone, for being here today. As a reminder, our roll call is going to reflect a newer requirement. Members must declare any conflicts of interest starting at the beginning of each meeting. No definition of conflict of interest in the federal rule. If you feel that anything in your personal or professional life creates a potential conflict of interest for your work on the MAC, declare it when your name is called. We will start our roll call. And so I'm here, Director Emma Sando.
Here.
Heather Jeffress, I believe, is excused today. Is that correct, Sarah?
That's correct.
Thank you. Healer Prochot is absent today. Jerry Weeks.
I'm here.
Good morning. Kaya Adams. We'll circle back to Kaya. Kelly DeVore. I see you, Kelly, though your audio did not come through. Good morning, Kelly. Lydia Dennehy.
Here.
Good morning. Ronnie St. John. I'll circle back to Ronnie. Shannon Buck.
I'm here.
Good morning, Shannon. Stacy Shaw.
Present.
Good morning, Stacy. Dr. Tony German. I'll circle back to Tony. Peter Starkey.
Present.
Good morning, Peter. Kaya, are you here? Okay. Ronnie, are you here? And Tony? Okay, well, Sarah will take note if they join a little later. Sarah, do we have a quorum for the meeting? Since
We do have quorum.
Fantastic. Committee members, last week you received draft minutes from our most recent regular meeting to review. Please take a moment to review the minutes for any errors or omissions. Do any committee members have concerns about the minutes? If there are no revisions, I also want to call attention to the consent agenda, which you also received prior to this meeting for review. Do I have a motion to approve the September meeting minutes and to acknowledge our consent agenda?
Hi, this is Jerry, and I move to approve the meeting minutes and the consent agenda.
Thank you, Jerry. Do I have a second?
This is Lydia, and I second the motion.
Thank you, Lydia. Any objections? Any abstentions? The motion carries. We will move forward on to our next agenda item to Medicaid Director Sando to share the latest news since last month regarding Medicaid in Oregon. So I'll pass it off to Director Sando. Thank you for being here today.
Thank you. Can you hear me okay? My Zoom is frozen.
Yes, well, it sounds like we're hearing you okay. Your video is frozen, but the audio is coming through.
Hold up now. Is this better?
Video is still frozen, but audio is coming through.
Okay, great. Apologies. I think I have to do a quick, I'm on the audio on my phone, and I think my computer has to do a restart in order for me to get my video back. So I'll be doing that in the background. It seems that my Zoom has been freezing every time it comes that I have to speak. So I don't know what's going on with my computer lately, but apologies for that. Thank you so much for having me here today. I wanted to provide a couple updates. I'll start on the federal side. Um, with the government shutdown, I believe we're in day 29 of the federal government shutdown. The Medicaid program largely is unaffected by the federal shutdown. CMS employees are working for almost entirely right now, and all of the funds for Medicaid continue to be provided. Medicaid is a mandatory benefit rather than discretionary, and the funds to continue running the Medicaid program are continue to be unaffected by the government shutdown. That being said, I know that a number of our other sister agency programs, such as SNAP and WIC, are affected by this shutdown, and as such, Medicaid has issued some guidance to CCOs and provider partners to remind providers of how to use the existing Medicaid benefits. For example, a person can have medically grade formula paid for by Medicaid. That's a medical service, and so that is one option that people have to pay for baby formula through the Medicaid program rather than through those other avenues that may be affected. We also have a variety of food nutrition programs and are working with our CCO partners on those programs, and knowing that we may be seeing some disruptions on the food side in the coming days and weeks. But the more significant changes are external to the Medicaid benefit and the Medicaid program. That concludes my update on the the federal side, we continue to work on implementation of HR1 and working with our partners on that. But I'll continue to have updates as we have more progress towards that implementation in the coming months ahead. I do want to turn my updates to state changes. We recently announced CCO rates that were provided in the contracts with a 10.2% average rate across our CCO products. And as such, we had a lot of negotiations through the rate process with our CCO counterparts. And this rate was more significant than what was included in the original state budget of the projected rate increase for 2026. CCOs are on a calendar year contract, so the contracts begin on January 1. And CCOs had a deadline in September to indicate whether or not they are participating in the next year's contract. Pacific Source provided us with a notice that they would not be participating in their Lane County product in 2026. We have been working with Pacific Source and Trillium, who is currently in Lane County, on what that would look like, and are working towards that transition of members from Pacific Source to Trillium, and have been working towards how we can make sure that there's the time and attention paid to the members transition, so that people who may have needs and providers that they're seeing are having a smooth transition of care as their CCO changes, and are working towards a February 1 implementation date of that transition in Lane County. I think I was able to finally restart my computer right when I am at the end here of my prepared remarks, but I'm happy to turn it over to see if there are any questions. I do see something in the chat of asking for 10 whether it was, I correctly said 10.2% increase, and yes, that was the CCO rate increase that we announced a couple weeks ago.
Thank you, Emma, for those remarks. We have, I've heard in some of the other work I'm doing that there have been discussions about potentially making changes to proposed quality payments for a value-based care. Are you able to speak to that, and how that is moving forward at all, or where in the thought process that is?
Um, uh, um, Hold on for technical difficulties.
Of course.
Hi, Caroline, it's Peter. I'm actually the liaison to metrics and scoring, so I can speak to that a little bit, maybe while Director Sando is working on it.
I think I'm back.
Oh, yes, you are. There you are.
Okay.
Hello again.
Thank you, Peter, but I will just say that at this time we don't have an update on that. As I mentioned earlier, the 10.2% increase was more significant than what was included in the past budget for the biennium, and so there are a lot of discussions with how we can ensure that the state is able to meet those rate changes. And I will have a further update once more is known on that policy.
Thank you very much. Kelly?
Is my audio working now?
Yes, it is. Thank you.
Thank you. Director Sando, can you also just speak to the projected increase in costs? I think sharing simply the increased revenue to CCOs versus not also articulating the projected increase in costs that CCOs are experiencing. It seems important to sort of share those two things together.
Yeah, happy to. Thank you, Kelly. The how rates are developed, and I apologize for not going deeper into that. Nor in past years, I don't think that we've um, had much conversation in the MAC or in other spaces on rates, but CCO rates are designed to be actuarially sound. So how when actuaries look at the utilization and costs of maintaining the Medicaid benefit, they see a window of this is the increase in capitation payments that are necessary in order to meet the next year's um, utilization and costs of healthcare covered services, and that is how the rate is calculated, and we are required as a state to provide actuarially sound rates. So what would be in a projected appropriate level of costs to administer the Medicaid program. I would just note that we are not alone in the country of having this level of rate increases. There's quite significant healthcare cost growth across the entire country, with a lot of other states also experiencing a significant increase in costs in the healthcare system after the pandemic and after other inflationary aspects of the healthcare system. I think Medicaid often is where you see it more acutely first, and then that shows up in some of the other data and metrics of the increasing cost of healthcare.
Well, I think we do need to move on to our next topic. I thank you for providing this insight into these changes. I imagine it has been a complex conversation negotiating these rate changes. And as always, I think we all appreciate the work that you and the team members are putting behind the scenes. So thank you for addressing these questions and providing us some insight today into this work. So thank you very much. So we will move on to our Beneficiary Advisory Council update. So our team member Lydia Dennehy will present on the back work since our last meeting in September. So our MAC and back member Lydia will now present. So thank you, Lydia, for presenting.
Right, thank you. So we had started with a consumer roundtable, and people shared what they were hearing or experiencing. So we had concerns about kids who are adopted out of foster care. When they turn 18, their benefits abruptly stop, while those who remained in foster care when they were 18, it continues to 26. And there's confusion among adoptive parents that they thought their child's benefits lasted longer. And then there was concern that compounded medications, so those medications made by a compounding pharmacy because somebody can't swallow or is allergic to some of the filler ingredients in manufactured medications, have to pay out of pocket. We had concerns about members facing food insecurity with potential loss of SNAP benefits. And then we had concerns about Pacific Source departure from Lane County and some of those patients who have ongoing care needs, and will they get continuity of care? We heard that Spanish speakers are afraid of being in the medical system. They're afraid to go to medical appointments. And then we were hearing concerns about gender affirming care and whether it was going to continue or how it was going to continue while safeguarding the privacy of the individuals. So a lot of different concerns this time. We learned about OpenCard and the CCO directories. There's a lot of confusion about how do you actually find somebody who's actually accepting new patients. So we were thinking about how to put in place a system that would take the burden off of the members so they don't have to call quite so many people. And we were wondering if CCOs and open cards could create an online form for member reporting so that if we hear from a practice that somebody is no longer there or no longer accepting new patients, can we just drop in a report? And then we were wondering if there was a consequence for the CCO or provider if they don't keep their entries up to date. And then how people without computers can access those directories. These are the questions that we had after the presentation. And then we got an update on how the plan was going to, how we were going to implement the work requirement reporting, and sort of what our role would be, since we have to balance adhering to federal mandates, keeping people covered, reducing harm and inequities, and we have limited time, and there are decision points that don't align with our schedule, so things happen and have to be decided based on federal schedule, not on the back schedule. And then we started talking about how the back and Oregon Health Authority can work together. Next slide. So we're thinking that we will add public testimony to our next meeting in a similar format to the MAC. And if there, and then we heard from OHA that there's grant money. So we'll have a professional facilitator for a year so that the agency staff can take a step back and be partners rather than be managers and facilitators. And we're also recruiting new MAC members from the back to fill open seats. So I won't be the only representative in the future. I think that's it.
Thank you very much for those updates. I think will be really helpful for the back to add public testimony, and it will be really beneficial for the MAC to have more back members, and it will be trying to not confuse MAC and back in my speech. And so thank you for presenting. Do other MAC members have questions or comments? I don't see any hands raised, so in an attempt to keep us on time, we will move forward to our dental performance improvement project update. So this is an overview of options for an oral health performance improvement project with a request to weigh in on which population to target. This will be presented by Lisa Bowie, the Quality Improvement Manager from OHA. Lisa, thank you for being here today.
Good morning, everyone. Can you hear me okay?
Yes, we can. Thank you.
Hello, I'm Lisa Bowie, Quality Improvement Director here at OHA. I use the she, her, hers pronoun series. I have a picture of Silver Falls behind me, black hair, red shirt. I'll go ahead and give you a overview of what performance improvement projects are, and then get into the oral health focus area that we're currently designing. So to add to the acronyms of BAC and MAC, I'm going to add PIP into your life today. Performance Improvement Project is the PIP acronym. PIPs are required by Code of Federal Regulations, otherwise known as CFR. It is also required in Oregon under our 1115 demonstration waiver that we do what's known as a statewide PIP. So here in Oregon, we have 2 statewide performance improvement projects. One is focused on integration, and the other is focused on substance use disorder or SUD. The other 2 are for CCOs to select within their local communities the topic areas. So I gave a little bit about the actual CFR or the federal rules around the PIPs for anyone who wants to do some light reading. There are the federal rules around that as well. Just for situational awareness, the statewide performance improvement projects do go through external quality review. So the one I'm speaking about today does go through what's known as EQR. Next slide. Here's a little bit of history since the CCOs have been CCOs, as well as there have been statewide PIPs. So as I said, statewide PIPs have been part of our 1115 demonstration waiver, and the topical areas that we have done for the integration focus. We have worked in the area of diabetes in people with schizophrenia or bipolar disorder. We have done safety, a whole host of things in the opioid areas. And so we've called it our high dose opioids. And that started in 2015 with aligning towards the CDC recommendations around high dose opioid prescriptions. And then you can see that we went into that opioid prescribing into lower what is known as morphine equivalent dosing. So that's what MED stands for. And through the years, we went into lowering that dosing for prescribing across the state. Then in 2019, we went from high dose opioid prescribing to acute prescribing. So on the other end of that would be acute settings like right after you have surgeries, dental procedures, etc. That was a very short design period in which then we were asked to pivot and go into mental health access or behavioral health access. And we created a Oregon specific metric, and that's where the CCOs and the behavioral health systems have been working for the last few years. And that was designed during kind of the pandemic time. Next slide. When you're designing a statewide PIP and trying to do it in alignment to the external quality review protocol, this is just the broad categories of the steps. There's the topic, and for performance improvement project, you need to have a goal, any quality improvement, and then you need a measure. So there's usually in collaboration with OHA and CCOs and our health system partners, we do topic selection, we do prioritization, then we kind of refine it. We go into goals. We talk about populations, look at health disparities. Then we go into how do we know where we'll be getting to achieve that goal with the measure. So those are really the high level steps to designing a PIP. Next slide. I want to go over kind of where we have started or where we have gone through this in the design stage. And this has been over the course of since the spring. And I see a pop-up. I just want to make sure. Okay. The development status in the spring, we landed, or late spring in June, we landed on oral health. So this is through the engagement with CCOs and partners. I helped staff another committee known as the Quality Health Outcomes Committee with CCOs and partners. And we engaged on that topic selection. Things from oral health, other topics, social emotional health, all those child health topics, immunizations, and in the end, oral health is what the topic was. But even within oral health, there's several areas that we could go in. So over the course of the next few months, we've asked CCOs to engage and review data and engage with partners to focus within oral health. CCOs completed a survey that was required. And then also we asked to participate in what is known as a prioritization matrix. That was optional to provide OHA feedback. We, OHA staff, have been participating in updates at the Oral Health Forum. That's the subcontractors, the dental subcontractors. We have been giving regular updates to the Metrics and Scoring Committee, and then as well as that committee known as the Quality Health Outcomes Committee. Staff, myself and Dr. Ahmed Farag, our dental director, has been engaging member-facing committees, the Health Equity Committee, the Ombuds Council, and then you all here in October. Next slide. So here's some of the results from the inputs from the CCOs and partners. So as I said, they completed a survey and then a prioritization matrix, and that engagement is again over several months and or the results of the required survey. The items on the left were actually in rank order. The items on the right are not in any particular order. So the survey results on the left, the topics within the oral health focus were oral health diabetes, oral health and prenatal care, and then an area known as, and there's a very specific metric that I'll speak about, but the area around ambulatory care and emergency department. So really known as people that go into the emergency department with oral health needs. Okay, so you can look at all those words around number 3, but it's really those people who have dental emergency or dental care in the emergency department. And they those on the right is the prioritization matrix. And the CCOs who participated in that and those engaged with their dental subcontractors, their community advisory councils. And again, in no particular order, those results were oral health prenatal. Again, those members who show up in the emergency department with oral health needs, and then oral health pregnancy and SUD, so substance use disorder. Next slide. So that was the narrowed focus. Things that have surfaced across the oral health topics, so just broadening it, things such as, and we've also talked about chronic disease and special healthcare needs. We've talked about, just broadly speaking, just all members. Just, do we want to focus on all oral health across all members? And then as mentioned, diabetes specifically as well. So we can focus on any one of these. One of the things that we have talked about is about measurement, and I'll address that here soon as well. Next slide. The Dental Quality Alliance is a national organization. They have multiple Center for Medicare and Medicaid service measures that are on the adult and child core measure set. So one of the things in our design is having a measure. As I said, there's you have to know how we're going to achieve our goal, and you have to have a measure. We've been consistent in saying that we're going to pick a measure that is aligned to our federal adult and child core measure sets, and or in other words, we're not going to use a homegrown measure. We're not going to design our own measure. We want to address what we've been hearing from the health system and have measure alignment, have a measure alignment to measure strategy. And so these are some of the measures that are available. There's a host of other measures, but these are some of the measures that the DQA has out there. And so that's some of the universe of the populations and the measures that are existing to the federal oral health strategies. Next slide. So we're at the part of the conversation of where we're going to go. Right now, we're finishing out, and there will be continued engagement, but we're finishing out the committee engagement on the design stage. We're happy to come talk about what some of the stages are after we get from the design into the performance stage. But then what we'll do is look at the performance measure and data viability after we refine the focus within or the topic within the oral health focus. OHA will then take the prioritization matrix, the input from CCOs, the input from the member-facing committee, the survey, and all this engagement, and we'll make a selection decision on the topic within oral health. And then let's go to the next slide. So what we really are hoping, when I say we, Dr. Ahmed Farag, I, and the other clinical leadership are looking is to hear from you all, Medicaid Advisory Committee, and our back representatives. What are the important areas for oral healthcare for CCO members? Are there populations OHA should consider, for example, age or health conditions within the oral health area to focus on for statewide improvement? So again, what we're trying to do is have all the CCOs work in one particular area. We will note that there are protocols, like I said, for external quality review. And so we'll be taking a whole host of factors in play, but I'm happy to answer questions on any part or open it up for discussion now.
Thank you, Lisa. So it sounds like to me that you're looking for our opinions on what to focus on, and that it is not limited just to the three main topics of prenatal, diabetes, or non-traumatic ED dental care. Is that accurate?
Yeah, so for instance, when we went to, and I see your hand, Lydia, when we went to the health equity committee, we heard access and pediatric when we posed the same question, and so that has helped frame Ahmed, Dr. Frog, and our conversation. We look at the array of measures. We are being very transparent and saying we do want to recognize the healthcare system delivery and doing measure alignment, not picking a topic that also adds administrative burden to the system, CCOs, payers, dentals, all the downstream. But we want to hear what are you hearing from your approach, from your, and so they had a conversation around access. They had a conversation around pediatrics, and we said, okay, we're going to take that in, and that's exactly where Health Equity Committee went. We've heard from the ONSPUD, so we will take all and then try and frame it into our options that we have available. Oh, you're on mute, Carolyn, and then I'll get to you, Lydia.
Apologize. Shannon just saying everyone needs to be covered for things like crowns, root canals, and when a tooth is pulled, last resort or replacement. Lydia?
This is an issue that comes up a lot with families of children with special health needs, that they have dentists who are afraid to work with their kids, as particularly if there's some sort of risk for anesthesia, and then also that they have dentists who don't want to work with their kids because of behavior needs, and being willing to slow down, and then just access for, just because a wheelchair can get in the door does not mean that somebody can get up onto the exam chair. So just like spatial access is an issue as well. And then we have a lot of families who get well water, and they sometimes have things in the water that affect their teeth. And I think there's very little knowledge or awareness of dentists, like how to help a family, I don't filter their water or deal with the damage that comes from the types of impacts that well water has on teeth, particularly in rural areas. And there was only one dentist in 2 counties when I was a kid who took Medicaid. And that was in Coos and Curry County. So we all went to the same dentist. So access is an issue.
So access, and in particular, Lydia, what I'm hearing is access in some certain parts or rural.
Mm-hmm. So
parts.
yeah, frontier and rural counties have a difficult time finding and keeping a dentist, and then transportation to get to that dentist can be an issue as well. So it's hard to maintain a regular schedule if it's a major thing to get. If you have more than one child, can we get all 3 in on the same day? All this, sorry.
Very similar experiences, even in my suburban integrated federally qualified health center I had worked for that you're speaking to. Maybe not as much as the access of provider workforce. Workforce is an issue, but what you're speaking to in the transportation and the scheduling of families. So I appreciate that comment. So thank you. Others, as far as your experience of oral health care for CCO members that Dr. Farag and I can take back as we're furthering this design, and or whether again it's in the performance improvement project space or as we are working with our CCOs and dental partners, subcontractors, and providers to improve oral health care.
Shannon wrote an additional comment. Unfortunately, currently there is no coverage for crowns, and teeth are often pulled that can be saved. Personally, I am missing all but one molar and cannot get bridges or replacements. Shannon, thank you for sharing your personal experience.
Thank you, Shannon.
I know working as a primary care physician in Portland, even at a well-resourced setting, it is for my patients within our CCO that access remains a challenge. Finding a provider that is within a distance that is by transportation remains challenging. Lydia is also mentioning some medications impact oral health as well. Ellen Pinney is our ombudsman, is asking, what is the timeline for getting you and Dr. Farag thoughts about improvement areas?
Right now, we are the design stage in formally by external quality review by December 31st, 2025. So we will have picked a topic and picked a measure. Again, that measure is going to come from the CMS, some national vetted measure by December 31st. Ellen, we will continue to work through our Quality Health Outcomes Committee meeting, which is if you Google OHA, QHOC, and I'll drop that link. We'll continue to give regular updates at that meeting. And we are going to continue to get regular updates at the Oral Health Forum. But we are likely hoping to refine topic discussions at November's meeting, measurement discussions between now or November and December. And that population conversation is how are people in the spectrum, child to senior basically, or older adults. And so that's where we're going to be having that likely in December as we look at different measures, or right now from what we hear from all y'all. Thank you, Stacy. I see your comment. I echo the rural access is a chronic issue. And so it is really around what I'm hearing is access is is a forever issue. Not forever, not going to be a forever issue. Well, hopefully not forever. It's been an ongoing issue, even when I was in my practice in the suburban Portland metro area. Access continues to be an issue. Rural, suburban, frontier, and I'm hearing, Lydia, I hear from you also for special healthcare population needs. I hear, Lydia, care for seniors is also an issue for those in institutional care. So this is all helpful in population and in geographics. I want to be mindful of your time as well. If you, I don't, Carolyn, as far as time, or Dr. Barrett, what?
We do have a few more minutes. I did have a question. I apologize. I can't remember who mentioned the concern about anesthesia and need for assistance for patients who might have behavioral challenges. Do you know if, or just need, even if don't need anesthesia, but need extra time, for physicians, we are able to, and this is a part of my job I hate, but we can bill on time and therefore can, in theory, be reimbursed on if we are spending more time with a patient. Is that, do you know, Lisa, if that is similar for dentists? If to allow, can they book a longer appointment time for patients who might need additional time? Just thinking about that.
From Lydia's example, and this also came up from, I think, when our other member engagement meeting, a similar scenario that you described, Lydia, in regards to the children with special health needs. To your question, Dr. Barrett, I don't know specifically. I do have recollection of how I used to do this, but this is like from 25 years ago, not from my integrated FQ8C, which also has slight billing changes, but this is from my time at OHSU. So when I worked at OHSU, Lydia, we used to help a lot of the special healthcare needs to do exactly what you're speaking of, which is the anesthesia visit, care coordination for children who had high needs for various different types of appointments. And to your point, Dr. Barrett, we used to be able to bill that on a physical health side, but the care coordination around this is very complicated, and what you can bill for and what services you can do. And I think when we start to get into it across the healthcare domains, whether it's physical health or behavioral health, then it gets really complicated from my experience, at least at the OHSU time. But that was also, we're going back like 25 years of my life. And so we're really stretching my memory as well. Plus, policies might have changed, but I can take that back to the oral health team and have them look it up as well.
What just occurs to me is that for, not for everyone, but for many people, not anesthesia is not necessarily always needed, which is a completely different level of care,
Right.
but sometimes slowing things down, talking is sufficient. And wondering what allowance there is on the billing side for reimbursement for providers. And then the anesthesia is obviously much more complex than, but allowance of time, which I know like Dornbecker is very good, for example, for like MRIs and doing non-medical sedation to help children, things like music and distracting techniques to help avoid sedation with an MRI that can be provided. And there are things like that that I believe, and I am not a dentist, that I think can also help in procedures like dental, that can help also for individuals with other special healthcare needs. So just other thoughts and wondering what allowances there are for that in dental reimbursement.
And to Lydia's comment, there are few specialty clinics available in Oregon. And again, as the statewide PIP moves from design stage to implementation stage, then we get to the discussion around interventions. We get the discussion around innovations and different practices that are doing the things to address the needs that are being surfaced right now. And so that is definitely a rich conversation to talk about who's doing what and where, and to connect those pieces to those who are doing those care coordination functions at the CCOs and the dental plans, and identifying the need to where it's at. So
We have time for one or two more brief comments. Are there any other thoughts, questions for Lisa for the performance improvement project in the dental arena? Okay, well then, Lisa, if you could drop that link in the chat so that we can, and then if Sarah and Tom, if you could send that out to us so that if we have thoughts later, that we can also convey those messages. Really appreciate you being here today. It sounds like our resounding theme is access, along with some other subtleties. Thank you everyone for participating. Really appreciate you being here, Lisa. So we will move on to our next topic. And I believe, so we are moving on to the subcommittee recommendations regarding the 2024 Ombuds report. We'll present the subcommittee findings regarding the Ombuds 2024 report with a focus on durable medical equipment. Sarah, I believe, is it Jerry who is presenting this?
I'm going to take this one. I know
You're
Heather
taking
was
this, Sarah. Wonderful, because I
originally
know
going to do
Heather
this
is
one.
not here. Thank you
Yeah.
very much, Sarah.
Okay. So just as background, as you may recall, a couple of years ago, we decided as a committee that we would elevate the reports that the work we were doing with reports that we were receiving from the ombuds to sorry, I distracted myself because I see a typo. Let me get back on track. So we've been getting the ombuds reports, of course, for many years. We voted, I think it's actually in 2022, to elevate the recommendations from MAC reports so that we were really engaging with these reports in a more robust way. And so at least for the yearly report, we would actually take some of those recommendations and put some more emphasis on them by endorsing them. So our first review was of the 2023 Ombuds report, and that happened, of course, last year. And then this year we have this report, which, as Dr. Barrett noted, was focused on durable medical equipment. I know that it's a funny thing because we're looking at a year back, and we've been talking about a lot of other issues with the ombuds over 2025, but we're looking at 2024 right now. So we did have a subcommittee that met to make recommendations, to discuss the report. And I think you all had a chance last week to see the report and review it in the email that we shared with you. So next slide, please. So there were three things that we wanted to elevate from that report. One was a recommendation about formalizing a form for durable medical equipment improvements. One of the ways that OHA was able to make many rules changes or around durable medical equipment was through the focus that the ombuds and others put on durable medical equipment in 2024. And out of that process, because the agency was able to hear from consumers and others about durable medical equipment, the agency made a lot of improvements to how durable medical equipment is being provided. You know, what we see in the report is that complaints about durable medical equipment have been rising. Some of that's because of having more emphasis on it, but also, you know, some of it is just natural. And the as we saw in the report, some of those issues affect OHP members in a really, well, outsized, it's the only word I can come up with for that, way, just have fundamental effects on their quality of life. Not just the, you know, yeah. And we have existing forums, certainly, but they don't have the capacity to focus on durable medical equipment. And so formalizing the kind of ad hoc work that OHA was carrying out in 2024 would be a good way to continue to address these concerns. Okay, next slide. So another really interesting recommendation that the ombuds included in their report was to ask OHA to work with the community to review complaints and grievances data. And I think, you know, we looked at that and thought about how that aligns with our focus on health equity outcomes from the HRSN implementation that we've been following closely over the last year or so, actually last couple of years. You know, OHA has declared a commitment to promoting member voice in policy advising and actually put a lot behind that, including the way that we've created our beneficiary advisory council and the work that OHA is doing with the Office for Health. Sorry, I just changed it. Office OHA. Office, sorry guys. Community health and equity. Help me out if you know. But
Community
and
health and engagement.
Engagement, thank you. And the creation of an engagement team within Medicaid, right? So there's lots of steps that OHA has been taking to promote member voice in advising the agency. I think this is another great step that the agency can take, and that is why the subcommittee wanted to elevate this recommendation. And then also focusing on community ID needs during budget constraints. That is a real opportunity for us to really stay focused on the member while we're thinking through how we're going to meet this moment. Okay, next slide, please. And then finally, the other recommendation that we wanted to elevate from that report was regarding assessing rules to advance health equity. So there are lots of rules and policies in place in OHA. This one seemed like really well aligned with the agency's 2030 goal. And again, it could lead to more efficiencies in existing programs. Just having an overarching review of rules and policies could uncover efficiencies, and that in turn might reduce administrative burden, which we know correlates with provider acceptance of Medicaid, which could also address some of our access concerns. So these were the kinds of things that we were thinking about when looking through the ombuds report and considering which of their recommendations to elevate. Next slide, please. So we wanted to leave the rest of this time just to discuss these recommendations and then see if we could come to a vote on the recommendations in that memorandum. Ready to take questions.
Sarah, is there a summary slide with the recommendations just so that we can see them all together? I know I personally am very visual.
That would have been clever.
Sorry, to put you on the spot, I apologize. Or maybe if we could look at them
Let me see
one
if I
slide
can.
at a time again. I don't know if anybody else would find that helpful.
I'll try to whip something up while we're
Apologies, I
doing
should
that.
have asked that beforehand. It just occurred to me though. What questions do other people have? I really appreciate our subcommittee for taking the time to review the Ombuds' very thorough report and working on what recommendations to further elevate to OHA. Thank you for doing this work.
Sarah really is the one who did it.
Yes, it was Kaya.
Yes.
I apologize. In my head, it was Jerry. It was you, Kaya. My apologies. I misspoke earlier. Thank you, Kaya. It was you and Heather. Thank you.
But mostly Sarah. Like
But mostly Sarah.
we reviewed Sarah, and then today I was like, I will speak only if I absolutely have to, and if it only means the world to you, Sarah, I will speak.
Well, Kaya, do you have additional comments you would like to make from your time working with Sarah and Heather?
Nope.
Well, thank you very much for
Yeah.
stepping forward to do this work. I genuinely appreciate it, and I know everyone else on the committee does as well. So, so if we could just, maybe if we could move to the next slide, just so we can make sure we know what we are being asked to vote on. So this looks like a slide that we are being asked to elevate. So we are being, just to be clear, we're being asked to vote to ask OHA to work more closely with the community, to work to review complaints and grievances data. Is that an accurate interpretation of this slide?
Yeah, I think that's accurate.
Okay. And you very concisely summarize why and explained why. And then the next slide is assess the rules to advance health equity. And then there was a third slide. Was there a third slide?
There was, and that was the first one in the series. It's the formalizing the forum.
Okay, formalize the forum. Okay, thank you. Thank you. Okay. So these are the three recommendations that we are being asked today to vote on to elevate to OHA. Do committee members have questions about these recommendations?
No questions.
Lydia does.
Yeah,
Was
sorry.
she? Okay, I just saw your hand. Sorry.
So we're asking OHA to make these things a priority, is that, or because complaints
Yes.
about DME being a high rate, I mean,
Yes, so for years, the number of concerns brought to the ombuds group have been disproportionately higher than other concerns, has been my understanding. More recently, I think that has shifted to concerns about HRSN, but historically in the last number of years, they have been disproportionately around DME. Would it be okay if I ask Ellen to confirm that? Ellen, am I
Yes.
interpreting that accurately?
Yes, that's
Okay.
correct. These were trends, and sometimes because of the impact on equity or specifically vulnerable populations, we will highlight issues that might not have hundreds of complaints, which we now have about HRSN housing. But that was this year. This was last year, and last year we determined that for the sake of equity and ensuring access to necessary care for vulnerable Medicaid members, we needed to focus on DME, which we
Okay.
also had a lot of complaints about. I hope that helps.
Thank you. What would people think about taking these recommendations and voting one at a time? I know my kind of linear brain would appreciate doing that. Would that help other people? Would that, Kaya, Sarah, that were involved in this, Kaya?
Yes. And so I am the health equity manager at the COO in Klamath Falls. And so I would even say from the inside that the DME could be even like a 5 times higher. And the frustrations and the complaints that I see from direct like facing members is that it's changing consistently. And so like last year belly bands were covered, this year they're not, and so it just changes all the time. And the biggest complaints that I hear from clients and members is, hey, this was covered last year, how come it's not this year? Like those are other frustrations and stuff that I hear the most on is the consistent changing of what is covered DME versus what's not this year.
Okay. And I'm seeing Lydia put some comments in the chat. Back spoke about right to repair or ability for local repair shops to bill Medicaid. We also see that delays in getting DME impacts children as well. They outgrow their DME before it arrives. That sounds incredibly frustrating, especially for those who go through puberty or other growth spurts. Are there other comments on the recommendation to formalize a forum for DME improvements? If not, I would recommend we make a vote on this one and then move to the next topic and discuss that and just vote one at a time. I think that would maybe ease things.
Caroline, I'm sorry. Can you clarify are we voting on?
I was recommending maybe that we vote on each recommendation one at a time rather than as a whole.
And is the recommendation to formalize the forum? Because
Correct.
Okay, thank you for that.
So formalize a recommendation to formalize a forum for DME improvements. So are there any other comments, discussion, questions before we move to a vote to make a recommendation to formalize a forum for DME improvements? Lydia, I see you came off mute.
Yeah, now that I know what it is we're asking, I'm not sure that we really need to separate it out. It's all about creating a forum. We don't need to vote on each individual
Can you move
point,
to the
I
next?
think.
Well, everything is
yes,
separate topics.
Yes. This is Lydia, and I move that we advise OHA to work with community to review complaints and grievance data. Or yeah, that we create a forum for DME complaints.
Right. Thank you, Lydia. Do we have a second?
I'll second. This is Jerry.
Thank you, Jerry. Any objections? Any abstentions? Okay, the motion passes. So then moving to the second recommendation, to work with the community to review complaints and grievances data. Sarah, can you say again, I didn't quite catch that. You were mentioning there is already a committee that is focused around this.
I don't know that that is true. But the ombuds would have to. I imagine no, there's not an existing committee reviewing complaints and grievances data, not something that exists outside of OHA staff. There may be some informal work going on that the ombuds is doing. They could speak to that, but there isn't any kind of formal focused effort to uh,
I
to do that.
Yeah, I will just say that we do have a call center that does triage a lot of the um, uh, similar conversations and complaints, and does maintain analysis and data around that, and resolves a lot of those complaints. That is different than formal grievances, but there is a process that does exist for resolving member issues.
Thank you. I know we're a little in not totally formal here, having Ellen participate, but Ellen, may I invite you to speak on this topic as you have your hand raised?
Yes. The Ombuds Advisory Council is working to reshift itself to become an advisory body for the ombuds, which means for our purposes, for our hopes, that Ombuds Advisory Council would be looking at complaint and grievance data received, as Emma pointed out, both from Client Services Unit and as reported to us by our CCOs, and as Ombuds has received, and to be looking for trends in that data, which includes, for folks who don't know, the grievance system includes denials, prior authorization request denials, appeals, and hearings. Our first meeting to see if this is going to work is December 15th. We invite anybody here to come. We hope for participation by BAC as well, and how MAC and the Ombuds Advisory Council choose to go forward together to review complaints in a public space. I'm talking about in a forum that includes both OHA staff and community partners. Is something I think worth considering. So that's what I would just say. Our first meeting to do this is December 15th, and Dave Inbody, our CCO Operations Director, will be coming, and CASU Client Services Unit will be presenting as well.
Thank you, Ellen. If you are able to drop that information in the chat for members of this committee and any members of the public that are present, that would be very helpful. Thank you. I appreciate knowing that this is in process, and I do think it would be beneficial for the MAC to add our voice to recommend to OHA that work be continued. Is there any other discussion on this particular recommendation? Otherwise, I'll make a motion that we vote on it. Okay, I move that we recommend to OHA that they formally work with the community to formally review complaints and grievances data. Do I have a second?
This is Kaya, and I second.
Thank you. Any objections? Any abstentions? The motions carries. And then to review the third recommendation is to assess rules to advance health equity. And are there any specific questions around assessing rules to advance health equity? Any questions or discussions on this topic? Were there, Sarah and Kaya, were there specific thoughts about what this means, or specifically trying to leave it broad to allow for room for some interpretation?
I think the way that we interpreted the report from the ombuds was that it is a broad review of existing policies and rules across Medicaid, and with the goal of really keeping in mind health equity and how those rules and policies affect our goal to eliminate health disparities by 2030.
So the
I
goal
agree.
of,
So it would be like the latter, Caroline, sorry.
okay, so conducting a broad rule of Medicaid rules with the goal of advancing health equity. Am I understanding that correctly? Sarah is nodding.
Yeah, that's right.
Okay. Any questions, concerns? Ellen, is there any addition you would want to make to comment you would want to make about the thought, since I'm guessing you wrote most of that report with your energy?
Right. I guess what I would say is reviewing all rules. We have just dug into HRSN rules. Any rule book of business takes a lot of time. I like Mac's focus on rules that might impact equity and think about calling out specific books or rules. It would be a full-time job to review all rules that we have because there are so many. I think Mac is uniquely positioned as well to look at open card or fee-for-service rules because they are kind of the entry level for CCO rules as well. So I would just say this is not only about CCOs, this is about impact on open card or fee-for-service clients.
And let me be clear, right? The MAC's role in this is to advise the agency and ask the agency to prioritize an assessment of the rules. It's not the MAC's job to do the assessment.
Thank you. Thank you so much. Thank you, Sarah.
Sure.
I started panicking. I was like, wait a minute.
Can you say that again, Sarah, please? Can you repeat that?
Yeah, our goal in making these recommendations or elevating these recommendations is to tell the agency these are things we want the agency to prioritize when it's thinking about how to parcel out work. And it's not, we're not saying that this is a task that the MAC wants to take on.
Yes,
Got
okay, thank you, okay. And so the idea that we're recommending, the goal of this recommendation is to recommend to OHA to review Medicaid rules with a focus on advancing health equity. Does that sound like the intent of what you are trying to convey with the recommendations?
Yeah, that's correct.
Okay. Committee members, are there other questions or comments for discussion prior to a motion? I don't see any hands. So I'm going to move to recommend that OHA review Medicaid rules with focus on advancing health equity as a recommendation from the 2024 Ombuds report. Do I have a second?
This is Lydia. I will second that motion.
Thank you, Lydia. Are there any objections? Are there any abstentions? The motion carries. Okay, so I believe we have made it through the recommendations for the 2024 Ombuds report. Thank you very much to subcommittee members Heather and Kaya and Sarah and Tom for helping lead that process. We are amazingly 2 minutes ahead of schedule, so we will take our break and come back at 10:40. I'm ready to get started for the second part of our meeting. See everybody at 10:40. And to work for incentive programs, we will explore ties between workforce incentive programs and Medicaid network adequacy. I apologize if I am saying your name wrong, but we have Deepti Shinde, Primary Care Office Policy Lead, Jill Boyd, Healthcare Provider Incentives Program Coordinator, Tim Nesbitt, Behavioral Health Workforce Manager. Thank you all for being here today. I will turn it over to you.
Great. I'm going to start us off. My name is Deepti Shinde. Caroline, you said that exactly right.
Fantastic.
I'm going to be speaking here today in my role as lead for Oregon's primary care office and speaking to you about some federal healthcare workforce incentives that exist. I'm also the lead staff on the state's healthcare workforce committee. Yeah, next slide, please. And I'm joined here today by two of my colleagues, Jill and Tim. Did you want to introduce yourselves?
Sure, thanks, Deepti. Hi, I'm Jill Boyd. I use the she, her pronouns, and I'm with the Healthcare Provider Incentive Program, and I'll explain a little bit more when we get to my slide deck. Thanks for having us today.
Hi, everyone. Tim Nesbitt. I use he, him pronouns, and I'm the Behavioral Health Workforce Incentives Manager with the Behavioral Health Division. Happy to be here.
Great. I'm going to start us off with the purpose of why we're here today. And that was because we heard from the MAC that they were interested in learning more about the state and federal incentives that exist that are managed by OHA. And the big overarching goal of these incentives is to increase the supply and retention of the healthcare workforce that serves really the whole state, but especially OHP. The OHP population. And we want to make sure that MAC members have the information needed around what's in our different programs, in their structure, and how they operate. And then maybe most importantly, we also want to provide an opportunity for MAC to discuss how our different roles interact and to ask any questions that you have about the various programs. Next slide, please. Great. So the outline for our presentation today is that I'm going to be going over the federal workforce incentives that are offered. And then I'm going to turn it over to Jill, who's going to go over the state provided workforce incentives. And then to Tim, who's going to be talking specifically about the behavioral health incentives that are offered. We'll be touching briefly on other healthcare workforce incentives, and then we'll go on to comments, questions, and discussions. Next slide, please. Okay, and we can move to the next one. Great, so the primary care office, which is myself and then also one other person who is part-time. She is a contractor and really a deep source of knowledge about these programs. So Oregon, like all states, uses federal designations called health professional shortage areas, or HPSAs, to identify areas and population groups that are experiencing a shortage of health professionals in the state. And so this map here shows one type of HPSA, which is related to primary care. And it's a little hard to see, but you can see that most of the state falls into a HPSA area, a health professional shortage area. Sometimes the HPSAs follow county lines. Sometimes they cover multiple counties. Sometimes they're down at the level of census tracts. There's really no rule. And so they're areas, but they greatly vary in what areas they cover. There's 3 basic types of HPSA designations that are based on the health discipline that's experiencing a shortage. So one type is primary care, the second type is oral health, and then the third is mental health. So 3 different types of HPSAs. The Oregon PCO, we collaborate with health facilities and communities to submit designation applications so that they can be eligible to be a HPSA. Then the federal government approves these designations and uses them to distribute resources that hopefully improve access to care. And I won't get too much into the scoring of the HPSAs because it's really detailed and very technical, but just really basically each HPSA, each one of these areas gets assigned a score between 1 and 26. And the higher the score, the higher the need and for federal resources that go into an area. There are many different factors that go into that score, but all the HPSAs include these factors, and those are the population to provider ratio, so how many providers there are in an area relative to how many people live in that area. Another important factor is the travel time to the nearest source of care. That gets factored into the HPSA. And then the third one is the percentage of the population that lives under the federal poverty threshold. So those are kind of the 3 factors that all HPSAs have in common. There's some other factors that are specific to mental health HPSAs or oral health HPSAs, but I'm not going to get into those. I just wanted you to have a basic overview of what those are. Next slide, please. Okay, so this slide really shows a visual of like the whole process and where our office falls into that process. And so over on the left, you have the practices and the providers from communities that are seeking these designations. And having a HPSA designation sort of unlocks different incentives that exist at the federal level. So it's very important for communities and practices to have that designation. The state primary care offices, each state has one. They work most directly with the practices and not the providers themselves. And so we work with practices from all over the state at different stages of their designation. Some are interested in just learning whether they're in a HPSA and can be in a HPSA area. Others are looking to see what their score is and whether that score is accurate and whether there's anything they can do to work with us to boost that score. Because like I had mentioned, the higher the score, the higher the demonstrated need and the higher resources or the greater resources you might be eligible for. So we work with the Federal Shortage Designation Branch, which is a part of HRSA. And then we also work with some other government partners as well, which are listed here. And then all of this, the goal of all this is to really get the resources into these communities and to get the providers in the most under-resourced parts of the state. Next slide, please. Great. And so I had mentioned that having a HPSA designation and having a high HPSA score can sort of unlock different programs and opportunities that exist. And so I wanted to go through one of these programs. It's called the National Health Service Corps, NHSC as an acronym. And so once a site has a HPSA designation, they can also apply to be a NHSC site and receive NHSC health professionals to work at their sites. So these health professionals receive loan repayment or scholarships incentives in exchange for a service commitment to work at one of these approved NHSC sites. And on this slide, you can see the table. So the data is a little old. It's about a year ago. We had 329 health professionals working in Oregon through this program. And out of these 329, they worked at 182 sites that were approved as NHSC sites. And the different programs have different incentives that can be offered to you depending on what your profession is. So, for example, a primary care provider can get up to $75,000 in loan repayment for a 2-year term by serving at one of these NHSC sites. Behavioral health and oral health providers get a little bit less. They can get up to $55,000 for a 2-year term. So as you can tell, it's a very important workforce recruitment and retention tool in Oregon. We hear from both sites and the practitioners that it was an important factor in them deciding where to work. And about 1/2 of these NHSC sites are in rural areas of the state. And so in terms of being a tool that can really get people to work in underserved areas of the state, it really is an important tool. So as I mentioned, sites apply to become NHSC sites through the federal government. And our office, the Oregon PCO, we help them with their application. You have to be in a HPSA to be eligible to apply. And then there's other requirements as well that we work with sites on meeting. Next slide, please. Great. So this slide just talks about the Oregon PCO and what our role is in this whole process. We provide technical assistance and other tools to help sites collect data. We conduct assessments on what type of options are available and will best meet their needs. There's actually quite a lot of different HPSA types. There's the geographic ones, there's HPSAs based on special populations. And so it really does involve looking at a particular area and figuring out which HPSA is going to work best for that region, the best designation strategy. We prepare requests and updates for reviews. HPSA data does get reviewed every couple of years. Providers, come and go. As we all know, they retire, they relocate. And so keeping that up to date is really important because if you're in a HPSA and you have a certain score and half your providers have left in the last couple of years, that is really going to change the need and change your HPSA score. So we want to make sure that all that is up to date. We follow up on application submissions. Sometimes there's, something wasn't done correctly or they need more information. So we help with all of that. And then there's also times when designations, they get put in what's called a withdrawal status for different reasons. And so we let those that are affected by those changes know and work with them on different strategies for keeping the HPSAs. We also provide information on any changes to the federal rules or state programs and services and how they're going to impact communities and practices. So that's kind of the Oregon summary of what the Oregon PCO does briefly. And with that, I'm going to turn it over to Jill to talk about state-funded programs. Thank you.
Thanks, Deepti. Hi, everyone. I'm Jill Boyd. I'm part of the Healthcare Provider Incentive Program, which is built within the Delivery Service and Innovation Unit, which sits Deepti as well. So she's one of my colleagues. And we're here to talk to you a little bit about our program and the work that we do and how we impact network adequacy. So the Oregon Health Authority Healthcare Provider Incentive Program was created under House Bill 3261 back in 2017. And the intention was to offer incentives to healthcare students and practicing professionals who are committing to providing culturally responsive care for Oregon Health Plan or Medicaid, as well as Medicare members. And then also practicing in a site location, either in a rural or medically underserved areas. And that's identified as having an insufficient number of providers to support optimal population health. And we'll talk a little bit about how we track that. We have several incentives that are part of the Healthcare Provider Incentive Program. We do loan repayments. We have healthcare loan repayment. That also includes oral health, physical health. We also have a behavioral health loan repayment incentive as well. We have primary care loan forgiveness, which is for students at practicing educational institutions. We also facilitate the contract agreement with the Oregon Health Science University for the Scholars for Healthy Oregon Initiative, or SHOE. We also have additional scholarships for non-OHSU students, which is a separate statute. So we wanted to create a separate scholarship process for those outside of OHSU who are interested in a health career field. We also have career pathways scholarships for students in high school and middle school who are interested in pursuing a healthcare career, either in behavioral health, physical health, or oral health disciplines. And we also are supporting some retention incentives currently for healthcare interpreters and behavioral health providers that are currently working in the field. Finally, we also offer an insurance subsidy. It's the Rural Medical Practitioners Insurance Subsidy, which focuses on providing medical malpractice subsidies to healthcare providers who are in a rural or frontier area. And we're going to go through all of those slides really quickly. So let's go to the next slide, please. So this is kind of our framework, and this is really the goal that we're hoping to achieve with the healthcare provider incentive opportunities. We really want to focus on as much downstream as well as upstream opportunities for those that are interested in becoming, developing an interest in a healthcare career, all the way to keeping them in their field of choice and being able to provide a living wage so that they can continue to do so by supporting them in other ways. So this is just kind of a fun little slide that we wanted to share with you that kind of highlights all the areas and points of intercept that we hope to support individuals in their healthcare career journey. Next slide, please. Okay, so this is just a little bit of information about, how we're supporting workforce diversity, access to care, and retention. A lot of this information, and I'll put it in the chat as well, can come from our most recent provider incentives evaluation report, which was published in June of this year. So we do a lot of data collection, a lot of longitudinal data collection with several of these incentives. But to the right side, you can see the incentives that we do offer. We do capture the number of recipients for each one of our programs. So we've have almost about 1,500. These are new recipients that we've had over time since the inception of the program, which really got going in 2018, and we're able to capture in our most recent evaluation through 2024. So for the incentives where we did collect race and ethnicity data, we are collecting the real D data now, which is race, ethnicity, language, and disability data. We also were collecting OMB data for a while. And so we kind of have a little bit of a hybrid with the transition, but we do really try to capture the diversity of our workforce that's going out into rural and medically underserved areas. We have 39% of students and practicing professionals who identified as people of color or tribal members. And we can quantify some of the, it's the Office of management and business, I think. Is that correct, Deepti? They have their own category for race and ethnicity data, which is basically just kind of asking like the basic race and ethnicity questions, but they don't get into language and disability. So we kind of transitioned over to that changeover when OHA mandate for real D data for all state funded incentives was beginning to be. Thank you. Thanks, Steve. I'm having some major acronym issues this morning. So we do collect, try to quantify how many students and practicing professionals will be able to provide patient services over time. So we're able to quantify that for primary care and dental care. So we have an estimated of, 1.2 million hours of primary care to over 1.5 million patients within the state of Oregon. So we're pretty proud of those numbers. We think that these have been very successful programs. And I'll share a little bit more about what we're talking about in the next couple slides. We also have some retention data available for 2 incentives. These 2 incentives are the only ones that require service commitment, so we can monitor them over time. And for loan forgiveness, which is one of our student-run programs, we have 89% retention. And for loan repayment, which is by far one of our more popular incentives, we've had 92% retention. And these are professionals that are staying in Oregon. Loan forgiveness is for students who decide to practice in Oregon, even up to 5 years after their service obligation is completed. It's a lot on this slide. I apologize for running through it very quickly. Next slide, please. Okay, so this is just kind of a breakdown of each one of our incentives. As I mentioned before, loan repayment is by far one of our most in-demand incentives for all healthcare disciplines. We award practicing healthcare professionals with tax-free funds to repay up to 70% of qualifying student loan debt in exchange for a service commitment at a qualifying practice site. And I know this is a laundry list, so I'm not going to go through this, but you can kind of take a look in your own time of our eligible practice sites. As Deepti mentioned, we do take a look at health professional shortage areas, both provider and site healthcare professional or health professional shortage areas. We've also expanded that a little bit. So if you're not in a HPSA designated area, you can still apply for these incentives. As long as you're in a practice site that serves Medicaid or Medicare patients and no less than the same proportion of such patients that are in the county, or provide essential healthcare services to an underserved population is determined by the Oregon Health Authority. So really looking at, are you serving a pretty high number of Medicaid or Medicare patients, or if you're in a state hospital or correctional facility, we also make some caveats for those providers as well. And then we also track this by having site applications on file, and we do this in partnership with the Oregon Office of Rural Health. To the right is a list of our eligible provider types, and it seems to keep on growing even though our funding doesn't change. So I'm not going to go into the weeds on this, but we try to support as many different disciplines that are serving our most vulnerable populations as we can with the funding we have available. Next slide, please. Primary care loan forgiveness is another one of our incentives. This awards full-time students who are within an approved rural training track education program to receive funding for their education in exchange for future service obligations. This really is one of our major incentives that focuses only on rural and frontier communities with the intention to help ensure that rural clinics have access to quality clinicians over time. So this, again, is a list of eligible practice sites, very similar to loan repayment. And then we also have eligible student types. Students must be enrolled in an academic institution that are in good academic standing and participating in a rural training track. One of our most recognized, I guess, as the Oregon Health Education Center, or the AHEC Scholars Program. That's through OHSU. Pacific University also uses AHEC Scholars. Really, any approved Oregon Rural Training Track, we would be allowed to be eligible if they're on if that's something that the educational institution is willing to adopt. And then we do require that once they are graduated, they need to find a job at a rural primary care practice within 90 days of graduation, or completion of residency or fellowships is applicable. So we tend to track them over time if they're doing some other work. Next slide, please. Thank you. So we also facilitate the Scholars for Healthy Oregon initiative in partnership with OHSU. This is a separate statute, so we do include this as part of our program, and it is a scholarship that provides tuition and fees specifically for OHS students in the 4 disciplines listed below. And there's a little bit of information about eligibility. Need to be an Oregon resident or from a rural heritage. We place some priorities on that. And then we do, again, they have to be in one of the 4 degree programs, and then they do have a service commitment that's facilitated through OHSU in one of these eligible practice sites, both in urban or rural areas. Next slide, please. And finally, we've kind of lumped all of our scholarships together for the sake of time. We have several different scholarships that are currently underway for students to provide tuition and fees to students who are interested in either a healthcare career, one of our healthcare career pathways, or to maintain student providers in a healthcare field. And we really are focusing on those who are willing to diversify the healthcare professional workforce, and those in kind of rural and medically underserved areas as well. So this is kind of a list of our incentive types right now, and just to kind of show you the impact that we're having, and hopefully, these are estimated numbers of incentive recipients, since this program is still underway and we're still collecting data. But we do have workforce scholarships for those individuals that are in post-secondary education programs. So phlebotomists, EMTs, CRNAs, any kind of allied health professional, or those that are also in graduate level programs are eligible to apply. We also have the career pathway scholarships we have that are currently underway for secondary schools to help with either CTE programs, or if they want to get dual eligible credit in college for a healthcare track. We have a variety of different opportunities, summer camps that are focused specifically on medical education. And so we're really excited to launch that. We also have a couple retention focused scholarships. We're working with MACBO, or the Mental Health and Addiction Certification Board, to support registration and advanced exam costs for current behavioral health providers. And then we also launched our healthcare interpreter scholarship to support the OHA approved training programs for individuals who are interested in continuing education or becoming a healthcare interpreter, or renew their certification. Next slide, please. And finally, last but not least, we have our Rural Medical Practitioners Insurance Subsidy. This is probably one of our oldest incentives that kind of got looped into the Healthcare Provider Incentive Program. This was launched under House Bill 3630 in 2003. It does provide partial malpractice premiums, subsidy payments, with the intention to support healthcare providers that are delivering babies, that are working with little kids, neurology specialists, especially those in rural areas where we're not seeing as many OBs. I live in a rural area, and we have a big shortage right now. So, and we also, with the intention to support independent providers that aren't supported by a clinic or health system. Some of the processes we are required for providers to submit a yearly affidavit to the Oregon Office of Rural Health, who's a partner with us. And then there are a few eligibility requirements for the insurance carriers listed below. And then the table at the right just kind of shows the reimbursement percentages. So we can reimburse up to 80% for those that are practicing obstetricians or providing certification in obstetrics care. And this is kind of a list of how many providers in rural areas across the state we're serving at this time. Next slide, please. Okay, so I'm going to take a pause and turn it over to my colleague, Tim, who's going to talk about another section of the state workforce incentives.
Awesome. Good morning, everyone. Yeah, just take it easy and sit back for a little bit, Jill. That was a lot. So yeah, really appreciate both of you in your presentation. As I stated earlier, my name's Tim Nesbitt. I'm the Behavioral Health Workforce Incentives Manager, also a licensed professional counselor, previously clinical supervisor, worked in domestic violence, offender treatment, and mobile crisis and other community-based health. So really happy to be here with you all today. Let's go to the next slide. Okay, yeah, so just to talk a little bit about history and sort of where the Behavioral Health Workforce Incentives team comes from. All the way back during the 2021 legislative session, House Bill number 2949 was written and passed. Now, it's important to remember sort of what was going on at that time. 2021, height of the pandemic, very, very chaotic time for the entire world, not just Oregon. And so from that, we gained $80 million. Well, actually, the state gained a lot more, but OHA got $80 million for behavioral health incentives programs. And so that was from American Rescue Plan Act funds from the federal government. So in 2022, however, the 2949 was revised into 4071. So the team was created in response to this to implement this bill. And we really didn't get staffed until about April 2022. So there was a little bit of a gap there until it was finally started to be implemented after the team got onboarded and everything like that. But from that, there was about, I think, 11 different programs came from that $80 million. And so we've got this listed here. So within the bill, they split the $80 million into two different buckets. They had $20 million for clinical supervision funds, and then $60 million for what they called workforce incentives. And as I said, it was split up in legislatively mandated that way. So from that, there was the main body from the clinical supervision grants. That was the clinical supervision expansion grant, which was available to all behavioral health providers. And then we've got the tribal behavioral health set aside that was for Oregon's federally recognized tribes and also the Native American Rehabilitation Association, NARA. So split between 10, and then we have the set aside for the community mental health programs that was made available for every county within Oregon. So the other pot, the larger pot, $60 million, also had a set aside for tribal behavioral health, which is $2.1 million. And then also a larger $4.5 million set aside for CMHPs. Now, so they were kind of split between those two funds. So I just want to name that right here. And then from that, there are these other programs that were created. We had a loan repayment program that we took over that was modeled actually after the program that Jill was just talking about. Now, it's kind of interesting here because we received this money, but then after that, we haven't received any funding since then. So what happened was the program actually moved back over to Jill's shop. And so that's why it might seem like this sounds duplicative. You know, if I'm talking about, oh, we do behavioral health loan repayment, oh, Jill does it too. Actually, it was kind of like, you know, there was a sequential side to this. It wasn't like, you know, it hasn't been duplicative and we're not all like kind of doing the same thing and not knowing about it. So similarly, we have a Shoei-like scholarship here, where we take care of where we split actually ties with HPA, our Jill shop, and then on our side we had behavioral health for that. So I thought that would be important to note here. But yeah, this is sort of the breakdown here. I'm not going to go through every single one of these, but I thought it would be important to just show sort of how that money was split apart. Let's go to the next slide. Now this slide, and I apologize about the acronyms, but this slide shows sort of a similar way of looking at how each program looks to sort of intercept and reduce barriers in the behavioral health workforce career path. I'll talk about the acronyms here in a second, but I also want to say that the acronyms are there and that this is a screenshot from a dashboard that we have that has not been published yet. We've had a dashboard to show where this $80 million went and what it went for since June. But you know, it's been stuck in approvals for forever, you know, from OHA leadership, and then now the governor's office keeps getting like lowered down on the priority list because I don't know if you've heard, but there's a few things happening at the federal level that may have caused some of that priority shifting. But anyway, to explain what we've got going on here, if you look at the top here, the training and education, initial certification, licensing, recruitment and hiring, and retention advancement renewals is sort of our pathway here and what we've sort of divided it out. And so our scholarships programs and then our tuition assistance programs, which is focused on graduate schools only, the tuition assistance that is, really seek to intercept and lower barriers for people entering into the workforce at this juncture. And then we've got ASWB, which stands for the Association of Social Work Boards. They proctor the exam, which is also called the ASWB exam, and that's what a master's of social work has to take, an MSW has to take to become licensed as a licensed clinical social worker, or maybe a CSWA, a clinical social work associate, takes to become a licensed clinical social worker. Thank you, Sarah. And then the BLSW is the Board of Licensed Social Workers. So that is the state board that regulates licenses and it issues licenses for those to become a licensed clinical social worker and some other licenses that they have. So what we did there is that we provided funding to these organizations to actually reduce the fees to exams and for licensure there. Same thing with MacBo. We actually provided them funding to completely remove fees for licensure and renewals, and then also exams, and then also they provided training on the exam prep and some diagnosis training for some of the certifications that they offer here. And so that's why that's kind of split between retention, advanced renewals, and licensing. Then we've got loan repayment that sort of spans all of that because we had people from lots of different areas within their career that were able to advance their career or be retained within that portion of their career. And then clinical supervision, which is a fantastic program that really supports clinical supervisors and supervisees. So it's really through that whole thing as well. And then bonuses and housing stipends was a program to provide hiring bonuses, retention bonuses, and housing stipends. And housing stipends were specifically for those in rural areas and those moving out of state into Oregon. And those were for those areas. And then we had the CMHP, which I discussed a little bit earlier. Let's go to the next slide. All right, so some of the highlights that we learned from our programs was similar to what Jill's program has found, even though ours hasn't been around as long and has, you know, had a little bit more turbulence with our funding resources. We did find similar results in our retention rates. So we've got, so one of the big highlights that we have is that our loan repayment program has been successful at retaining people into Oregon's behavioral health workforce at a rate of 89%. We found that this clinical supervision program is effective at increasing both the number of credentialed providers and number of qualified clinical supervisors. That's because it supports the training and the payment of clinical supervisors to actually provide clinical supervision. It's an incentive for them to do this because that's where a bottleneck is. When you've got a bunch of supervisees that don't have anyone defined for supervision, they might have to go outside of their agency to pay for it. Even at CMHPs, or CMHPs might have to, locate somebody to contract with. This helps bridge that gap with that. And then on the other side, it also helps provide incentives for supervisees to focus on community-based mental health providers or substance use providers to find clinical supervision at those sites. Then we've got another thing that we found is that reducing costs to students and trainees through scholarships and tuition assistance incentivizes them to advance their careers. It's very effective in rural areas. Tuition assistance that's provided by an employer, especially in the case of CMHPs. That's yielded some of the highest retention rates. I'm showing from our dashboard the 85% at that. So, and then clinical supervision, as well as 89% in that realm. So providing, and then the last one, providing flexible spending options for incentives to community mental health programs and similar team-based care programs. It's led to most incentives maintaining around an 80% retention rate for those that receive them. Some of the ones that weren't so popular that were instituted that were actually named in the bill as incentives were part-time and flex time opportunities. So when implementing that, they found that they only saw maybe around a 55% retention rate that within those people that received that. And also childcare was a very hard, and even though ideally it sounds like a great incentive, it's really hard for an employer to implement something like that. So that was something that was not very popular. It retained high retention, but it wasn't very popular for employers to do it because it was just such a nightmare for them to implement something like that. Lots of liability concerns with that. So some of the lessons that we learned from these programs that they're very high in demand. From our loan repayment program, we were able to offer or we allocated 16 million out of that 80 million towards loan repayment alone. When we got all of our applications in, we had over, I think, 240 million requested from all the applications throughout the state. So that alone is just massive, interest and demand in these things. They do take time to yield results. Things like clinical supervision, you're talking at least 2 years to gain your license from start to finish after you've graduated grad school. And then obviously education takes time to get through as well with the academic calendars. We found that equitable service commitments are more effective than not. So equitable underlined is because the reason why equitable is underlined is because the juice has to be worth the squeeze, right? You have to make sure that the service commitment is on par with the incentive itself, that it will be enough of a trade-off for that person to stay. And smaller and rural providers often need more technical assistance, we found, and reducing burden for applicants and recipients means constant improvement. So that's something that we do regularly, is looking at how we can improve things, how we can make things easier for our recipients while gaining quality information about how the programs are running. So yeah, I think that's my last slide.
Well, thank you so much. We do just have a couple of minutes left. I want to thank you so much for your very comprehensive presentation. I'm really impressed by how many number of provider types that are covered and the number of programs. I had a quick question, and I see Kaya had a question. For For the retention data listed in both the physical health and behavioral health sections, are they staying at the loan repayment sites for the 5 years, or are they staying within Oregon?
So we calculate it both ways. So we look at, so these are this is up to 5 years after their service commitment period, which is a maximum of 3 years per round. So it's a little bit confusing, but providers can reapply for our loan repayment program up to three times, and we'll pay up to 100% of their student loan debt. So they could have a 9-year service commitment. We haven't had this program about long enough to be able to track post that 9. If we do have some awardees that are involved in that, so but we haven't been able to see them pass like up to 5 years past that 9 years. But those that are in a 3-year service commitment, we can track up to 5 years post their 3-year service commitment. We track whether or not they stay in Oregon. So that 92% is those that are staying in Oregon at a qualified practice site that is either the same that they started at or a similar. So if they were at a federally qualified health center during their service commitment, but they moved to another federally qualified health center, like we categorize that as part of that retention data.
Okay, thank you. So it is still staying within serving the
absolutely. Yeah. And we have kind of a more enhanced breakout in our program evaluation report. We just for sake of time, there's so much information to include on these slides. We just didn't make everybody's head spin around. So
thank you.
Yeah.
Kaya?
Hello, it's Kaya, tribal woman, Modoc, she, her, Klamath Falls. I just had a question for a few slides back. I might have missed it. I wanted to see if will there be will the recredentialing and stuff like that get covered again? Do you know?
Yeah, are you talking about my slide for MACBO and social workers?
Yep.
No, there's no plans at this time. There isn't been any approval of funding. And so no.
Okay.
I will say, because we work so closely with Tim on a lot of these incentives, our healthcare or our retention program is currently underway with MACBO, which is very
nice.
We kind of took a little bit of what they were doing, and we're able to extend it with some of our funding. So registration costs and examination materials is all covered under our $1.35 million grant agreement with MACBO that will extend until 2027.
Okay, perfect. Thank you. Yeah. Thank you. It was time for recredentialing. And so I'm like, oh man, I should have got in there or timed it just right to where those were covered. Thank you.
Yeah. And our last question from Lydia, do the behavioral health incentives have ongoing funding?
So the behavioral health specific ones that I was just displaying do not. But as Jill was mentioning, behavioral health providers are eligible for the programs that they have. And then there's also a new program coming out soon from my office that is much more condensed and has a much smaller amount of eligibility requirements. I guess larger amount of yeah. It's more stringent, much more stringent eligibility. Focused on community behavioral health programs and other team-based care programs, and it's a much smaller amount of funding, about $3.7 million. So yeah, that's sort of a complicated answer, but the programs that I was showing for behavioral specific, no, there's no ongoing funding.
And for our program within the healthcare provider incentive program, we did receive a $6 million carve out with our legislatively allocated budget in the 23-25 biennium, specifically for behavioral health services. And we received the same amount in the 25-27 biennium. So we are legislatively required to, which we're happy to do anyways, but we're also legislatively required to allocate that $6 million for behavioral health workforce efforts in this biennium that we're currently in as well. What that looks like in 27-29, it's anyone's guess, I suppose.
That is a different bridge to
That's
a
right.
bridge in that biennium. Well, thank you so much, DT, Jill, and Tim, for giving us all of that information. We really appreciate you being here. We will move on to public testimony. The Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Department of Human Services, the Oregon Department of Human Services, excuse me. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal comments, public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. Committee staff will communicate the next steps with each public commenter. Sarah, do we have any public commenters that we know of waiting today?
We haven't had any requests to give public comment. Thank you.
Well, then, do we have any members of the public waiting here today that would like to give public comment? I see Matt Sarah's raising his hand. Matt, I welcome you.
Yeah. So my name is Matt Sears. I'm the Public Policy Director for the Oregon Council on Developmental Disabilities. I just wanted to come today to offer some insight into some feedback I got from family members this week who are trying to use the one or Oregon Eligibility Partnership one application process, which I understand the one system is used also to access benefits for Medicaid. The concern is that when applying through the one portal and working to fill out those applications, they ask for a lot of income related information. However, in the case of individuals or children with IDD or intellectual developmental disabilities, they're typically, a lot of these families, children are qualifying based on their disability alone without it being related to the parental income. What's frustrating parents is that, there's no way to avoid the income questions, which are very intrusive and cover a lot of material. When a lot of these parents know that they don't qualify based on income, that it's based on their child's disability alone. So what could be a very abbreviated process, basically just proving documentation through through medical documentation of their child's disability, becomes a really arduous process that digs into a lot of bank records and other things that are unnecessary. So I guess, the purpose of the comment is to suggest that MAC may want to look into this issue and consider the fact that these income inquiries present a barrier for parents trying to apply.
Thank you for your testimony today. Are there any other members of the public here today that would like to comment? And before I say that, Ellen Penny, our ombuds, has messaged you, Matt, saying she would like to talk to you about this challenge. She's aware and would like to explore more. Are there any other members of the public that would like to comment, give testimony today? I'll just leave it a moment before we move on. If there are any members of the public that are here and would like to provide written testimony, you are welcome to do so. Okay, I am not seeing anyone else raising their hand to provide spoken public testimony today. So we will move on to MAC discussion. I want to provide a reminder about the November education discussion. Am I remembering correctly, Sarah, that that is on November 12th at, I'm looking at my calendar, 9:05 a.m. is what I have written on my calendar. Is that correct, Sarah?
Yeah, that's correct. And this is going to, for reminder for folks, this is a session around Medicaid's place in Oregon's health care system. And we will talk broadly about that. Well, that's not what I mean to say. We'll have a presentation from Medicaid Director Emma Sando on Medicaid's place in the healthcare system in Oregon.
I
Public
personally
is
look
invited. Yeah,
forward to that very much. So I know Director Sando had to step off for another meeting, but I'm personally looking forward to that a lot. Sarah, I believe I cut you off. Were you saying that the public is invited to attend?
that's right.
And then Lydia had put in the chat regarding public comment. Oh, Tom is answering right now. Okay, about the email for public comment. If people do want to leave written testimony for public comment, that is in the chat. So circling back to MAC discussion. So yes, November education session, November 12th, 9:05 a.m. And for members of the public, Sarah, would that Zoom link be posted online?
Yeah, we will share that through our usual networks. And Tom, if you can grab that link out of the meeting invite, we can put that into the chat now as well.
Wonderful, thank you. And the next, I am.
You could turn that one over to me. I could talk a
Okay,
little
yeah,
bit
that was, I
about
was going to put that. I was also, and turn that over to you.
Great. So we, as you may recall, the one deliverable that we have historically done as a Medicaid Advisory Committee is an end of year letter to the agency describing our work. And with the new rule from CMS, they have formalized that on a federal level to have the MAC produce a report, which in the past, our reports have essentially been, here's what we've been doing. Please put us to work, OHA. These are the kinds of things we work on. The letter that is described in the rule is very much like that and includes suggestions from the MAC, recommendations from the MAC for improvements to Medicaid in the state. And those recommendations would take into consideration also what the Beneficiary Advisory Council is hearing through their meetings as well. And in addition, that there's a component of this report that would, by the time it is published, include a response from OHA regarding those recommendations. So I wanted to point out that our report this year, our process will be different. In the past, we've generally, around this time, chosen a committee, and then that committee will work, a subcommittee will work with me to produce the letter. Then we bring that for full committee discussion in December. And then have a vote in January. what I believe our process will look like going forward is that the MAC and BAC staff will draft a letter in December. At that point, we'll appoint MAC and BAC subcommittee to review that letter, meet with that subcommittee in January for revisions, bring it to full committee discussion also in January, bring it to the BAC for discussion in February because of the timing of meetings, bring it to the MAC for a vote in February. So then the vote would happen in the Beneficiary Advisory Council in March. Then we would get a response from OHA by mid-April. And then the OHA response, and this is tentative, right? I'm still working with OHA to ensure that this is all doable. The OHA would come back to the various committees in April, and then we would have a final vote at the retreat in May, which I imagine is going to be a joint retreat between the MAC and the BAC. So, and all of that is so that we can publish by the deadline. And our goal is to publish by June 15. So, I'm bringing this up because it's a change in our process, and to just have people start thinking about whether being on a subcommittee to review a draft report is something you can do in starting in December and then going into January. And again, this is the job would be reviewing the report and then meeting with the subcommittee to discuss it and create revisions to that report. So there it is. I'm planting a seed in your minds, and I hope to have some of you take that up. That's what I wanted to say about the end of year letter process. And then we have one other topic that we wanted to talk about. Do you want to take that one, Caroline?
Before you say that, Sarah, I was just going to say maybe about that subcommittee, if you had any thoughts, that maybe you could send in a follow-up email of like how many meetings you think that will be, just to help, like if you hadn't help to help people be thinking about that, since December is often a busy time for people, but just to help people's formulation. So, and then
Yeah, we can send that out with more detail.
yes, just to help people's thoughts. And then another item of business is that Heather will be coming to the end of her term on the MAC it's either January or February. I am not sure which. Sarah, do you know for certain?
Yeah, January is her last meeting as
Meeting.
co-chair.
So we will be needing a new co-chair to join me starting in February. So if you are interested in becoming a co-chair of the MAC, Heather and I have worked with Sarah to put together some information about what the role is like, what kind of time commitment it is. So if you are interested, please reach out to Sarah and Tom. My last meeting as co-chair, because the co-chair term is a maximum of 2 years, will be finishing, I believe my first meeting was in June of 2024. So I will be ending in May or June of 2026. So then we will be needing a second new co-chair starting next June or July. So just planting that seed. So we will be having some leadership change of the MAC starting in 2026. So we will be needing 2 new co-chairs in the first 6 months of 2026. So Sarah has information about the role and the time commitment. And of course, Heather and myself are happy to answer questions as well. Are there other items of business or additional discussion that other members of the MAC would like to bring to the table today?
Hey, I have one other thing we wanted to talk about, a policy rubric, and yet another opportunity to join a subcommittee to help us hammer out the details of a rubric that will provide oversight as just as the Beneficiary Advisory Council, as you heard earlier today, they're going to be considering a lot of things as federal changes go through, but we're trying to figure out how to work with them, so because we know things are, our meetings aren't going to line up well with the decision-making opportunities. So we want to try to find a way that works so that we're being proactive instead of reactive. With the MAC, I think we've talked, the co-chairs and I have talked about creating a policy rubric that would kind of guide our decision-making about guidance to the agency so that we can be, again, more proactive with the agency in talking about essentially what values we want the agency to take into consideration when implementing the changes that are coming down the pike.
I think in addition to that, the hope is that it would also guide future subcommittee conversations and perhaps shorten some of the future shorten some of those future subcommittee conversations, so not having to recreate the wheel, so to speak, with every future subcommittee meeting. And if we have some North Stars, so to speak, of what we are trying to, how we are trying to help guiding principles in terms of eligibility and services that we are hoping will be maintained, that perhaps that could help future subcommittee work, is my thought as well. Knowing that there might be repeated requests for recommendations from the MAC, and that maybe this this rubric could help be used repeatedly. That's our thought. And maybe we're wrong and it won't be, but that is what we are attempting. So these are some of the subcommittee work that will be coming up here. Other items of discussion that anyone from the committee would like to bring forth? Okay, then I will turn the meeting back over to you, Sarah, to close us out.
Great, thank you so much. So in the spirit of continuous improvement, I'm going to ask folks for the roses, the thorns, and the buds from this meeting, the things you enjoyed about the meeting, things that felt a little pokey today, and things in the meeting that you'd like to nurture for the future. Kaya.
I appreciated having Jill from OHA be able to answer questions that the one guy wasn't able to speak to. I think was his name Nick, sorry. But like with the funds and other questions that we had for him, it was helpful to know that OHA actually has funding for that. I wasn't aware of that, and I'm usually aware of most things. And so I really appreciated Jill's feedback and input and saying, hey, actually, we have funds for that. It's going to be helpful across the board.
Thanks, Kaya.
In that same presentation, I appreciated learning how many programs there are and how much effort is being placed towards workforce development. We routinely feel the lack of access, and I appreciate learning about the efforts that are in place to improve that, including the efforts like starting in high school and kind of pipeline access. So I appreciate that on a positive note.
Great. Any other roses, thorns, or buds, folks?
I also want to again appreciate the subcommittee work and elevating concerns and recommendations from the Ombuds report to OHA. I know that elevating Ombuds work has been a focus of this committee for some time now, and I appreciate that moving forward.
Same. I think Ellen is she just seems like a rock star. That's the energy she brings, like radicalism, advocacy, footwork, all the things. We appreciate her.
Much deserved retirement coming up, Ellen. I hope you are going to go walking on some beaches.
I appreciated that shout out, Kaya, and all of you. Yeah, I'm here till January. I'll see you at your next meeting. Thank you. I put my observations in chat. I love this meeting and this group and what you do. So important.
Thank you, Ellen.
Okay, thanks. I also see Lydia's comment in the chat about timing going well and information being both new to her and understandable. So that's helpful to know. Okay, I'm gonna stop fishing for compliments, and we'll close this meeting out. We'll meet again online on Wednesday, December 3rd at 9:05. That's our regular meeting, and between now and then, we will have our special educational session about Medicaid's place in Oregon's healthcare system. That's on November 12th at 9:05 a.m. and that's just an hour. So we'll hope to see you then. Thanks so much, everybody.
Thank you.